Hello, I'm Dr. Jay Shore, and welcome to the Administrative Considerations for the Department of Psychiatry's telemedicine programming tutorials around the COVID situation. Let's dive into a brief overview of some key administrative considerations to be aware of when doing telemedicine. First of all, licensure and credentials. Providers need to be licensed in the state where the patient is physically located at the time of the video conferencing session. So all of us in the department hold Colorado licenses, and so our patients should be in Colorado during our video sessions. Sometimes patients do travel and will actually video conference in and may not on purpose let you know where they are at the beginning of the session. So it's important to note that, and again, not see patients via video out of state. You can certainly talk with them on the phone. Our credentials and malpractice for doing this are covered through the CU system, and we are able to do telehealth from home at this point and home, and we're able to see the patients, our patients directly in their home, and that's CU medicine approved. An important note, which is one of those rapidly evolving situations. Let's talk about outside of the COVID crisis. So outside of this time period, when you prescribe a controlled substance over video for a patient, you have to comply with the Ryan-Hay Act. This is a very complicated act about prescribing of controlled substances using technology. The brief summary of how best to be compliant with that act is to see a patient in person first, and then at least once every 24 months in person to remain compliant with the Ryan-Hay Act. There are exemptions to this that get complicated, which I will not go into in this tutorial. As of today, March 17, 2020, the Ryan-Hay Act has been waived, which will allow you to go ahead and prescribe controlled substances to patients over video without meeting that in-person exam requirement. If a default position, which I would advise that we follow, is that as possible, we continue to comply with the Ryan-Hay Act, understanding that once the COVID crisis is over, by federal regulations, once the emergency is declared over, then we will have to comply with the Ryan-Hay Act. And so, so those patients that we saw during this time, we will then need to begin to document in-person evals, and so we will need to track that. So again, I think if possible, seeing them in person even now is optimal and ideal, but we can see them. The act has been waived, and we need to prioritize patient care. So we can go ahead, see them over video, prescribe the controlled substance. But again, I think it's important to be aware of this act, and that it will, once this emergency is over, we'll need to continue to comply with its rules and regulations. Shifting gears to talk a little bit about protocols. It's in my time in practicing telemedicine, every service that I have had has had a written protocol document that really spells out how things are done, including workflow, rules and regulations, how to manage emergencies. Recognizing how quickly we are standing up video conferencing right now today in the department, each service may not have an individual protocol. We have the general guidance that was issued yesterday that can serve as a protocol for doing telemedicine direct to patients within the department. And then that protocol can also be further adapted to individual clinics, workflows, and their in-person protocols. Within that protocol, if you go to the last appendix, you can see that in addition to licensure, each of the different licensing boards within a state may have different rules around seeing patients for the different specialties. So for example, doctors and nurse practitioners within the state of Colorado really don't receive much additional guidance about doing telemedicine except to maintain good standards of care. This is in contrast to the psychology professional boards, which strongly recommend seeing a patient in person first before beginning telemedicine. Actually, today we've had another clarification from DORA around this guidance for psychologists and other licensed therapists, that they recognize, and this guidance basically says that they recognize that this is a recommendation, but particularly during the COVID crisis, that they understand that this recommendation may not be able to be followed, and it may not be in the best interest of the patient. And so as of today, that recommendation is coming out from the other licensing boards about not necessarily waiving that in-person requirement as a recommendation, because that's what it is anyways, but sort of acknowledging that under these circumstances that providers should prioritize patient care and do what they see as in the best clinical interest of the patient. And again, in this case with COVID, we don't want them coming in, we want them to be seen. And as I had said, that we'll all need to be mindful once this situation begins to resolve as we go back to regular rules and regulations about what we do to stay compliant with that. Billing, in general, most services that we can do in person are covered under reimbursement for telemedicine. That's because we live in a telemedicine parity state. It becomes a little more nuanced when we provide direct in-home services about what is actually being covered. The general guidance that we've to date received from CU Medicine is to prioritize patient care. So outside of the COVID situation, we would have our administrative staff find out what our patient's insurance is and find out which home telehealth services, if any, could be reimbursed. In this situation, we should go ahead and see the patient in their home setting, and then work with our staff around their insurance billing, and our staff at CU Medicine may need to work with the insurance companies about what exceptions are going to be made at this point. Again, another update as of today, during the COVID crisis, Medicare, which had a requirement that you had to be in a healthcare provider shortage area to be able to bill for in-home visits for Medicare, that's been waived. So we will try and keep people up to date on the general guidelines around billing as we go forward. That's more for information. I think we, again, as I've been saying, we'll prioritize the patient's seen. And then a brief note on documentation. Some of your services and clinics that you work in may have standard telehealth templates, some may not. If there isn't a standard telehealth template, and this is also covered in the guidance, but the minimum documentation that doing a telehealth visit with a patient is you want to put your location, whether it's home or an office, and if you don't want to be writing your home address in the documentation, I would just indicate your home. For the patient's location, I would specifically indicate their physical location at the time of the video conference, which should be a home address. I have personally, depending on your level of comfort, I have actually seen patients in cars when they've had good, not driving, when the car is not moving, when they've had good video connection, because that was the only place we could get that was private. If you intend to do that, please consult with me and I'll tell you how to address those situations and document, but clearly that's an exception, not the rule. The third piece of documentation, patient provider location, you want to document how they were seen, which in this case would be over live interactive video conferencing. If it was a telephone or a different type of platform, you would document that. And again, there's further guidance in the protocol around this. Let's briefly cover emergencies, which first let me share and state that I've been practicing telehealth for 20 years now. I have dealt with a number of clinical emergencies, both one-on-one with patients or in clinics, a whole range of emergencies from suicidality, danger to self, losing touch with reality, psychotic types of emergencies, as well as threats and harms to others. And the bottom line about dealing with emergencies is we're trained to do this. We do this over the phone all the time, and to use those principles of good in-person care that you would if a person was in the room over video. For every patient, when you're beginning to work with them over video, you want to define and educate what the emergency protocol is up front with the patient. I'll get into this too a little bit at the end of clinical considerations. But with new patients in particular, telling them, what the emergency protocol is during the clinical session, but also how they can access you or services or coverage after hours. You need to know the patient location, of course, and that's where the documentation in the beginning of the session, the chart, and confirm where they're at. I think you certainly need to be aware of potential issues interacting with local emergency services. 911 in Colorado is a call that gets traced to your location. In some states, it's really a local call. So obviously, if I am sitting here on INHome's medical campus today and dealing with a patient in another county, say Grand Junction on the Western Slope, and I call 911 and they're keyed into my location for support and help, I need to let them know this is a call for someone in this location. The other trick that you can do is very quickly, if you Google emergency numbers in Colorado, there's a state-based list and website by county that will tell you sort of the backline number where you can call and interact with paramedics, police officers, other emergency personnel directly. And so that's always an option. Finally, if you have a patient and you're going into an in-home encounter that you know is at high risk for possible crisis, you can pre-consent via, you'll have to make these arrangements via telephone. You probably would not know with a new intake, but it could be an existing case where you pre-consent and someone, a family member or close friend who may be in the household or next door, you ask the patient to get them to sign a release of information so you can talk to them. And then if an emergency would arise in session, then you have someone you can call on the ground to help you with logistical arrangements. And also, you can even bring them into the session, which I've done before to help with the management. And so that's another tool that can be used. Again, I would emphasize that these are rare events. They do happen. And using the principles of crisis management, remote management that we see in the crisis management phone lines can help you successfully navigate a situation should it arise. So that concludes our review of administrative issues. So the next video in order would be technical considerations if you're interested in joining me over there.